All right, we're on to environmental emergencies now. So this week we'll cover altitude. So when you travel up, when you get over to levels of about 2,400 meters, you can start to get acute mountain sickness. And acute mountain sickness is pretty broad, but there are two particularly problematic presentations of it. One is the high altitude cerebral edema, and the other is high altitude pulmonary edema. It's very common, as you can see. It occurs in up to half of people who travel to these high altitudes, but the majority of mountain sicknesses are quite mild. It'll just be a headache and then some other fairly non-concerning symptoms. And they will often self-resolve as the body slowly gets used to the higher altitude. There are some high-risk populations, for example, the elderly and the young, which is pretty normal for any medical problem, tend to suffer worse. And obviously the higher you go, the worse it tends to get. The more rapidly you ascend to, this is particularly problematic for people who, fly in to Nepal or something, and then very rapidly ascend to Everest Base Camp, for example, and they don't give their body any time to acclimatize to the higher altitude. Now, the pathophysiologies of the conditions, whether it's that high altitude pulmonary edema or cerebral edema, are actually the same. And it's a result of vasoconstriction following a capillary leak, which results from long-term hypoxia. So when you start going high up in the atmosphere, the ratio of gases doesn't change. There's still 21% oxygen up there and 78% nitrogen. But as you can see in this graphic, at the lower pressures, as you go further up, while the ratio is the same, overall, there are just less gas molecules up there. So it means that even though you're still breathing 21% oxygen, there's just not very much oxygen up there, and you start to become, mildly hypoxic over a prolonged period. So the presentation of the mountain sickness, as I said, normally reasonably benign. So it's headache plus one of these other symptoms. And these should resolve and slowly get better every day, as long as they don't progress into those very serious cerebral or pulmonary edemas. Now, in Australia, we don't have any peaks this high, but if you do travel overseas as part of a group, or if you do work for like International SOS or something, if you have any of these patients with these presentations, because the problem is hypoxia, the treatment is oxygen. But that's only a fairly proximal treatment, and you're not going to be able to carry enough oxygen on you to treat these patients for the days that it can take to get better. So you can stabilize them in the short term with oxygen, but the definitive treatment is that they are going to just have to descend, usually not all the way down to sea level, but at least to a level where their symptoms are manageable, and then they can slowly begin to ascend again, giving their body an appropriate amount of time to acclimatize. There is a drug called acetazolamide, which causes bicarbonate excretion in the urine. Because you're excreting bicarbonate, it makes your blood more acidic. Because your blood is more acidic, your body tries to compensate by breathing more rapidly and more deeply. And that has the beneficial side effect of increasing oxygen delivery. So acetazolamide is an effective treatment to take anytime you are going into high altitudes prophylactically, but it also does help even after acute mountain sickness has developed, just by making you, without even thinking about it, breathe deeper and more rapidly to deliver more oxygen. And on the next page, you can bring a portable hyperbaric chamber, which is a fascinating piece of technology, which inflate, and you can put a person inside there and pressurize it. And so even though you can be very high up, say 4 or 5 kilometers up, you can pressurize that to less than 2 kilometers and stabilize the patient that way, which again is proximal, but will help stabilize them so that they can get well enough to descend on their own.